So we'll get started, Chief. We're good to go? All right. Welcome to Alabama EMS Challenge. We're down at Mobile today. Thank you, Mobile Fire, for bringing us down. We really appreciate it at the convention center. We got a good day today. We're going to do some EKG reviews, a couple of STEMI cases, and then Dr. Eversull is going to talk about non-cardiac chest pain, the deadly causes for that. We'll do lunch from 11 to 12, and then at 12:30, we're going to do some skills labs. We got a few pig trachs for surgical airways, but more importantly, we're going to do pig crew CPR, do some advanced airway, and then run some mega code scenarios as well. But this is time be open, ask questions. There's nobody intimidating here, I guarantee you, except for Chief Ward. He's the only one that's kind of scary. So, yeah, no, nobody laughs. Great. So my clicker is no longer functioning. So we EMS Challenge. We started this back in the end of 2014 to provide physician-led Con Ed in the Birmingham area. We started it working at the Old Highlands or Health South Hospital one day a month, and we kind of moved to an online format a couple of years ago. We won't go to the details of that at this point, but for your certificate, for you guys in the room, you can scan the QR code and take you to a link to fill out online. That link will be in the chat box, or you can always email alabamaemschallenge@gmail.com to get your Con Ed today. A couple of updates. November is the next state EMS conference. It'll be at Orange Beach. SMEC meeting will be that week as well. Remember, we do have a YouTube channel if you need Con Ed. The registry extended their distributive, what do you call that thing, where you can watch the videos, get Con Ed for 2022. They extended that for one more year. So you can watch our YouTube channel, get Con Ed from that. And don't forget, COVID is a real thing. It's out there. If you haven't got your vaccine, get your vaccine. That's a great movie to watch before you get it. Pretty enjoyable. That was funny too. Thanks for not laughing. All right. So 12 leads. So you can get way caught in the weeds with 12 leads. I kind of think of 12 leads as a screening tool. Keep it fairly simple. You rule out the big and bad things. Okay. Obviously, every 6 months, every year, I go back and relearn the vectors or read the Dubin's cardiology book. But that's not good for me in practice. So I'm going to kind of tell you the way I look at 12 leads. I think at pragmatic 12 lead interpretation, I think of EKGs, are they too fast, are they too slow, are they okay-ish? And that's the way I kind of break these things down. And I use that to screen out my patients to see if they're sick or not sick. Things you're going to have to know how to do is calculate a rate. Do not trust your monitor for a rate. So if you print out a 12 lead and it gives you a number, I always find a way to correct that, double check that. When you start looking at more advanced tachycardias, atrial tachycardia, some of the AFib RVRs, you got to be able to figure out your own rate and not the machine, because the machine's not going to be able to do that. Other thing you got to know is the interval. So you got to know what a good PR interval is. Really only matters in what? Hyperkalemia, right? So first 3 heart blocks don't scare anybody, not significant. But when you got a wide PR and you got somebody that's high risk for hyperkalemia, you consider that that's what they got and you treat them for that. You got to know the QRS complex. If you can't figure out a QRS, if it's wide or not, you can't determine if you got a bundle branch block or if you got a wide complex tachy or a narrow complex. The QT interval is very important. Without knowing the QT, there's some sort of medications we give that prolong the QT that can cause problems for our patients. And also, a prolonged QT interval is a good reason for somebody to pass out or have syncope. And you can catch that and actually save somebody in the long term with it. So QT interval is very important as well. So when I look at 12 leads, I look at this when I say, is the rate too fast, too slow, or is it okay-ish? I'd say that rate's in the 60s to 70s, so it's pretty okay, so not super scary rate-wise. So the next thing I'm going to do is I'm going to look at injury patterns. So I'm going to look at leads 1, AVL, and 5 and 6. These are my lateral leads here. And I'm looking for ST elevation or depression in any of these. If I got 2 leads with ST elevation, that's a STEMI, right? So it's easy. There's no wall time when you go to the hospital, right? They should get you back or they get in trouble. All right. The next place I look at is leads 2, 3, and AVF. Those are my inferior leads. Same thing. I'm looking for ST elevation, which would be concerning for a STEMI if I got in 2 leads, or depression. Next place I look is leads V1 through V4. These are our septal leads here, 1 and 2, and our anterior leads. So ST elevation in any of these, right, is concerning for a big LAD and septal anterior STEMI. You also look for depression. So depression, ST depression, T-wave inversion in those leads, that's diagnostic for a posterior infarct, right? So you can get kind of fancy with this. You can say, okay, the guy's got T-wave inversion, ST depression. Let's put the leads on the back and do a posterior EKG. You can see that taught about in some of the blogs. I'm not going to do all that. I don't have time for that. My job is to manage this patient and kind of screen this patient in for STEMI or no STEMI. So if I see this is a STEMI equivalent. I'm going to be talking to a cardiologist. You guys should be talking about putting this patient into the STEMI system that's going statewide soon and getting to the appropriate hospital. So ST elevation, T-wave inversion, V1 through V4 is concerning for posterior infarct. And a lot of times your machine won't pick this up. The last place I look is lead AVR. Was that me or was that Thunder? That was me? Oh, good. I was concerned. Thank you, sir. So that's place I look is lead AVR. So in the past, I always look at leads 1 and AVR. They should be opposite. So if I'm pointing up in 1, I should point down in AVR. That tells me my leads are on correctly. In reality, though, if I'm elevated, if I have ST elevation in lead AVR and I got depression anywhere else, inferiorly or laterally, that's concerning for a left main occlusion. In 2013, American Heart started saying that's a STEMI equivalent. Doesn't mean it's a big STEMI needs a heart cath, but it means you should be talking to that patient, getting a good history, talking to cardiology, and potentially going to the cath lab. So my advice, if we see ST elevation in lead AVR, depression anywhere else, we call that as a STEMI till we confirm it's not by a cardiologist concerning patient. So after I go through all those injury patterns, I go back and I look at my interval. So I look at my P-wave interval, my PR interval, I look at my QRS, I look at my QT, and I make sure all that's appropriate. And then before I get done with this EKG, I go back one more time and look for injury patterns, because there's some days I've been up way too long, haven't had enough coffee, and I don't want to miss a STEMI, right? Those are things we can actually intervene on and fix these days. All right, so what if I have an EKG that looks like this, though? It's a little bit different. If I look at it, I say, is it too fast, too slow, or okay-ish? I say the rate's okay-ish, so I'm 300, 150, 100, so a little bit over 100, all right? I look at injury patterns. 1, AVL, make me a little uncomfortable. 5 and 6 is T-wave inversion, ST depression concerning. 2, 3, and AVF looks funky. That's not a medical term, but it does look funky, right? V1 through V4 makes me pretty concerned, and I go back and look at AVR. I start looking at my intervals. I got P waves, right? Now I look at my QRS interval. My QRS is pretty wide. My QRS is greater than 120, so I got a Y complex rhythm. So that tells me that something else is going on. So this is actually a left bundle branch block. The machine does great at picking up left bundles, but once it picks up a left bundle, it's not going to really interpret that for a STEMI or not STEMI for you for the most part. So it's pretty important to figure out if this is a left bundle or not. So knowing that QRS complex, is it too wide or not, is pretty important. So is this a STEMI or not a STEMI on this one? What do y'all think? Yes, no, or maybe? The doctors can't answer. You know the answer. You're not tricking me, sir. No, you can go ahead. Sorry. Yeah, right. So new left bundle, you know you have some pretty significant injury to the heart. So new left bundle is a STEMI. We've been saying that for years. In 2013, we kind of said that all left bundles are not STEMIs, but if it's a new left bundle and the patient is diaphoretic, looks like dirt, ashen, it's a STEMI. Most people who get a new left bundle, that means they have pretty significant damage to the heart. They're going to be symptomatic. They're not going to be sitting there smoking a cigarette saying my knee hurts, right? Cool. So left bundle branch blocks are caused by anything that jacks up the left side of the heart. So left heart gets enlarged for some reason. It stretches out that conduction system and it slows conduction to the left side of the heart. So that's why you get that YQRS complex. We're not going to talk about vectors. I want y'all to stay awake, all right? There's some criteria that look at left bundle branch blocks. So the things you can look at. A lot of ways to look at textbooks. Again, I use this as a screen tool, my 12 lead. So I'm going to say the things that I look for that are important are going to be the QRS has to be greater than 120. If the QRS is not wide, it's not a bundle branch block. If I want to see a Q wave in V1 and no Q in 1 or AVL. So somebody's talked in the past about, you think about turning the indicator. If you're driving down the road, you turn left, QRS goes down, left bundle. So I got a Y QRS. Greater than 120. In V1, complex is going down. I got no Q in AVL, so this is a left bundle. So now we got a guy who tells you he has a history of left bundles, but having chest pain, diaphoretic, shortness of breath. The question is this a STEMI or not now? Don't really know, right? So there's a way we can look at some of this. There's a criteria called Scarbosa's criteria that we can look at. And the short version of this is discordance in a left bundle is good. The QRS complex going away from the T wave is appropriate. We should be pointing down and then up. We should be pointing down and up, right? So discord is good, all right? Concordance is bad. So if I have a QRS complex pointing down, any of the V1 through V4, and I got depression T-wave inversion, that's concordance, that's like a posterior, that's concerning. Or if I got a QRS complex going up and a T-wave going up, concordance, that's concerning. The other thing you think about with scarbosis is this discord is great, but if you get more than about one big box, it's concerning. You probably ought to think there's some kind of acute infarct going on. So with left bundles, remember, discordance is good, concordance is bad, and if you have ST elevation more than one big box or 5 millimeters, it's pretty concerning. So going back to this one, when I say this one's a STEMI or not a STEMI with a left bundle, I would say I got discord everywhere. If I'm looking V1 through V4, I do have ST elevation, but it's not more than 5 millimeters. If I know this is an old left bundle and I'm comfortable with that, that is not a STEMI, okay? However, I'd rather you be concerned about this and put them in the system, have somebody see them, send the EKG to the hospital, talk to your doc when you get there so you're not missing things, but that's a reassuring left bundle. Inappropriate humor, everybody likes this one, keep you awake. All right, what about this QRS complex? So rate's okay, not too fast or too slow. I start looking at injury patterns, all right? 2-3 and AVF, that makes me uncomfortable. V1 through V4, I got T-wave inversion or biphasic, and I've got ST depression. I look at AVR. I go back, I look at my P waves, then I realize my QRS complex is greater than 120, it's a little bit wide. So I go straight to V1 to say, is this a left bundle? And it's pointing up, so it's not a left bundle, it's a right bundle, right? So upright in V1 with the right bundles, is anything that causes right heart strain can cause a right bundle branch block. It delays conduction through there. And with a right bundle branch block, you'll sometimes see these deep T-wave inversions, and that can be a common occurrence, okay? However, I would say that if someone's having chest pain, the diaphoretic, they have symptoms of acute coronary syndrome, and this EKG is present, I'm not gonna say that's a normal right bundle. These guys still go to the cath lab, still see the cardiologist, and this we can get biomarkers to prove otherwise. Left bundle is anything that jacks up the right heart. So long-term COPD, pulmonary hypertension, folks who have pulmonary emboli, you'll see a right heart strain as well. And the way I look at this is I think about that QRS complex in V1. It should be pointing up. And then sometimes to the ST depressions, septal anterior. So again, this is a right bundle. The machine's not going to interpret a lot of these things for you, but it's there. Questions, comments, statements within reason? Not even smiles. This is a tough crowd this morning in Mobile because it's so cold in here. All right. So again, if I've gone through my whole routine, again, before I put the EKG down, I look one last time to look for STEMI equivalent, something that we can intervene on before I get tired. This is just a little schematic that I pulled off the internet that kind of shows the injury patterns. So if you think about elevation and lead AVR, we'll be coming way off the aortic root where both the right and left coronary come off. V1 through V4 is you're going down the center of the heart, LAD. The circumflex covers the lateral, which is 1 AVL and 5 and 6. And usually the right coronary comes off and goes down 2-3 in AVF. Sometimes the right side of the heart is supplied by the left circumflex, but most people it's the right side. And this is just, what's wrong with this image here? I show this a lot on the classes. Anybody see what's wrong with that one? That picture? It's American healthcare at its finest. Yeah, that blood pressure, you can't have a 79/80. I don't think you can, right? So just remember, the machine doesn't do a great job at interpreting things, even numbers sometimes. So when I talk about basic paramedic education at places where I'm helping with the program, we expect that paramedics can read 12 leads, okay? Look for STEMI or no STEMI, understand dysrhythmias, know those things. The left bundles to right bundles, that's getting a little bit more experience. That's fine if that takes some time to get that, but we should be able to interpret our 12 leads and say, is this a STEMI or not a STEMI? Cool. All right, first case. So we got a 62-year-old male. He's weak, has some nausea, had one bout of emesis, and he's now diaphoretic. So what are we going to think about doing for this guy for an assessment? Y'all like vomit? Everybody staring at the vomit. Good, yeah, it's my favorite body fluid, vomit. Yeah. Sweet. So what are we going to do for this guy? Yeah, perfect. So just hands-on assessment, right? So when I think about There's the protocols give us a lot of information, but in reality, what we're gonna do for these guys is I'm gonna get a history and a physical as I'm doing my primary exam. We kind of teach our residents that you go into a room, you do a history on somebody, then you do your physical, then you step out and you think about what to do. That's not what we do in the pre-hospital world or the ER. It's all one big thing. So I'm gonna approach this patient. I'm gonna check my ABCs. Hey, are you okay? Can you talk to me? I'm gonna sit down, hands on the pulse. I'm getting a great pulse rate with that. I'm determining are they hypotensive or they're not hypotensive. Is the skin warm and dry? As I'm doing that, my buddy's getting them on the EKG, getting the monitor, getting a set of vital signs. And we're working kind of as a team, okay? So obviously we're talking about 12 leads. We can get an early 12 lead. These guys need early 12 leads because you think about acute coronary syndrome is not just chest pain. It can be the old person with nausea, the old person with weakness. It can be the diabetic who just doesn't feel well. Those are, again, EKG is an easy screening test. There's no risk to it. You're not going to hurt somebody. And it's going to buy you some time, get you off the wall if you find something abnormal there. Questions that I ask these people, what kind of past medical history questions you want to ask folks like this? What things are pertinent and why do you ask them? Does anybody even care this morning? Yes, sir. Right. Yeah, I love that one. Have you ever had this before? They say yes. And I say, well, what happened? I was having a big heart attack. Well, in my brain, I'm like, well, crap, maybe this is the second one, right? Give me the answer. I'm not proud. Don't make me work for it, right? So what you're doing with your history is you're risk stratifying your patient. You're looking for reasons to help you determine, are they sick or not sick, and how fast do I move? If they were an 18-year-old with nausea and vomiting, I'm probably not going to move to an EKG pretty quick. If they're a 60-year-old with a zipper scar on their chest, right? And they tell you they've had diabetes and other issues, I'm gonna be moving to an EKG pretty quick. So all our questions for past medical history risk stratify your patient to determine how fast do I move on them, are they sick or not sick. Medications, I don't care if they're on torvastatin, some kind of hyperlipidemia medication. Other medicines are important. So what drugs are important to ask to somebody like this? Past medical history drugs, yeah, medicines they're taking. Man, this is a quiet, I feel like I'm at church. This is good. So yeah, so I think the same thing. So a lot of times people don't know what the health problems are, but you ask them what the medicines are and it gives you a lot of information. If I ask my patient, are you allergic to anything? And I say, I'm allergic to Haldol. What does that tell you? They've taken Haldol before, right? So that's a red flag, right? So good. So same thing. What medicines do you take? If they're diabetic, do you take shots or pills? Okay, don't try to get fancy with that. If they take shots, you assume it's insulin, they're higher risk. If they're on pills, you assume it's type 2 diabetes, less risk. But still, other questions I think about Viagra for pulmonary hypertension or for recreational use. All right, are you on blood thinners? And that's half of America these days. Okay, these are things that kind of risk stratify your patients. And the other things I think about is cocaine use, because cocaine use can lead to big coronary issues, especially the way we treat those in the hospital. All right, so enough talking. This is the EKG. What do y'all think? Too fast, too slow, or okay? Okay, rate's okay. Yeah, I would say 300, 150, 100. Yeah, close to 100, maybe a little bit more, a little bit less. That says 95. Doesn't really matter though, right? 95 or 105, same difference. All right, so rate's okay. I'm gonna look at injury patterns. I'm gonna look 1, AVL, and V5 and V6. I'm gonna look 2, 3, and AVF. I'm gonna go back and look at V1 through V4 for elevation or depression. Then I go back and look at AVR. 1 and AVR are opposite directions, QRS complex. AVR is not up. Now I'm gonna look at my PR interval, my QRS interval, my QT interval, maybe a little long, but not scary. But then before I put this thing back down, I'm gonna go back one more time and look at 1, AVL, 5 and 6, 2, 3, and AVF, and V1 through V4. So what do y'all think? Concerning, not concerning, STEMI, no STEMI, anybody even care? Concerning, what do you see, sir? Okay. I agree. I would say 3's got pretty good. I say 3's probably got maybe 1.5, 2 millimeters, probably 2. I don't have my glasses on, but it makes me uncomfortable. I start using profanity, right? All right. What about AVF? I say AVF's got enough in it that I'm gonna be kind of sweaty too. So machine says sinus rhythm, non-specific STT wave changes, borderline EKG. Well, machine's wrong. We just all agree this is a STEMI, right? So it's very important that medics in the field, ER docs in the ER, we interpret our own 12 leads because the machine would have missed this. Now you're on scene for 20 minutes, getting a bit of history, talking to the family, petting the dog. You go to the ER, you're on the wall for 40 minutes, things change. Very important. So this now becomes a critical patient, right? So now what do we do for this guy? We got a 60-year-old guy, nausea, vomiting, having a STEMI. How do we manage him? What are we going to do? Hugs. Ma'am? Diesel? No, come on. Yeah, you need some diesel fuel, but need other things, right? Yeah, perfect. So of those two, which one do you want to give first? Yeah, I like aspirin too. So you think about there's the old Mona mnemonic, which is morphine, oxygen, nitro, aspirin, not a O, or fentanyl, oxygen, nitro, aspirin. Aspirin is probably the most important because you think about the causes of acute coronary syndrome. So you probably got a big clot or thrombus there that's going to get bigger and bigger as those platelets adhere to each other. You give the aspirin, and that's going to help decrease the size of that infarct. It's not going to reverse it, but it makes it not get worse. The guy puking, I may slide him a little bit of Zofran real quick first. Makes it work easier, right? A little bit of Zofran, a little bit of fluids, then he gets aspirin. Cool. If his blood pressure is stable, he's gonna get some nitro for us. What does nitro do? Dilates, right. So if I got a clot here and I dilate this, I get more blood flow, and in theory, it's gonna make the heart perfuse better. So a little bit of nitro is reasonable. What about oxygen? He's breathing 16 times a minute and his sats are 97%. I hear no, yes, no comments. Yeah. All right. Okay, so American Heart says you don't need oxygen for these folks. I got a little bit of different opinion, but American Heart says they don't need oxygen, so I won't argue that with you. What does morphine do for these people? Yeah, decreases blood pressure, decreases preload. You get a histamine response. That vessel may open up a little bit. You get better blood supply. What else happens with some people that get morphine? They get nauseous too, so just be aware with that. In reality, morphine just makes you go from I'm having chest pain, I feel bad, to like I'm high as a kite, I don't really care, I have chest pain, right? So it's American way of life. So when you think about these STEMIs, you got a couple of things that can cause these. You can have somebody who has bad heart disease, calcifications, right? And these just get bigger and bigger and bigger to the point there's no blood flow. More commonly would be they have these plaques that rupture and they float downstream and it occludes off an area that's already kind of thrombosed down some. So aspirin is very important for these folks, very important. I would also argue that oxygen is probably okay for most of these folks. I'll come back to that. When folks with STEMIs get to the hospital, there's a couple of things that we can do for them. One, we can give them a medicine called TPA or TNK, which will take this clot and make it break apart and float downstream. The other thing we can do is go to the cath lab where the docs put a guide wire in and they inflate this balloon and it kind of crushes that plaque down. They put a stent in and improves perfusion. But when you think about the TPA, if you're going somewhere that doesn't have a cath center, we can, in an ER, give a medicine to open up that vessel. There are some risks to that. The drugs are TPA, TNK. Some states use Retivase. That's a pre-hospital thrombolytic that's used. When I worked in Tennessee, they use that in a couple of counties. So basically, someone would have a STEMI on the EKG. They emit the clinical picture of it, the chest pains, and then we kind of go through these risk factors. Are you at risk for having major bleeding post this medication? Major issues would be any recent spinal surgery, any recent GI surgery, any recent GI bleed. Are you already on blood thinners? That puts you at a higher risk to bleed more, okay? Have you ever had an aneurysm or a hemorrhagic stroke? Those kind of folks, you really can't give them a blood clot busting drug, right? They can bleed into the brain, have a bad outcome. So state says this is in our protocol book, and I know everybody here has seen this form and fills it out with every chest pain STEMI that you run, right? Yeah, me too, right? So my point to this information needs to be gathered, whether you put it on that form or you write it on your glove. This information needs to be gathered and given to the ER physician when you get to that hospital. So we have that information in case the patient goes into cardiac arrest or becomes altered, and we have to make a decision, can I lyse this guy or not lyse this guy? This is in the protocol books. Put this to memory. It's not complicated. Some places are asking for the form, some places don't. But either way, that information should be obtained by you guys, and that information needs to be given to the ER physician when you get there. Pretty important stuff. Same thing we do for our strokes, we do it for our STEMIs. So back to the oxygen question. So I agree, if someone is not tachypneic, not hypoxic, not short of breath, they don't need oxygen. However, in the pre-hospital world, I argue that if I have someone having a STEMI, they're at high risk to decompensate, go into cardiac arrest. So I don't give them supplemental oxygen, I give them kind of pre-oxygenation. So if you're the person in the back of the ambulance with them and it's just you, and they're on 2 liters and they go into cardiac arrest, you can crank them up to 6 to 8 liters as you pull over to start CPR, get ready to defibrillate. and it's pre-oxygenation for cardiac arrest. There's no data out there that a little bit of O2 for a short amount of time is going to hurt anybody. There's good data that high flow O2 long-term for people can make some free radicals and have a bad outcome, but short-term is not going to hurt anyone. So my practice is I tell folks, yes, if I got a STEMI, they're critical. They get on some pre-oxygenation in case you got to go to passive oxygenation and they go into cardiac arrest in the near future. If I send in the hospital the patient from the ER to the cath lab where I'm working, they get on O2 as well because they're moving in transit. And that way, if they decompensate, it's easy. You lay them back, you put them on high flow. If nothing else, you got passive oxygenation until you can get an advanced airway and defibrillation. What else do they need besides O2? STEMI patients, what other things we got to put on them? So big risk with STEMIs is to evolve into VTAC or VFib, right? So this was a patient, big STEMI, medics did a good job, filming some something O2, gave him an aspirin, put him on the defib pads, en route to the hospital. He starts having a seizure. Was he having a seizure? No, he was not. He was dying, right? His brain was dying. But they recognized that. They just charged a 200 and give him one quick shock and got return of spontaneous circulation. So STEMI patients get defib pads. Not all chest pains do. You run broke, you get fired doing that. But STEMI patients are high risk, especially if you're transporting low staff and you got one guy in the back of the truck, they get defib pads. Can make a big difference. Sorry about the sound, but this is an EKG from a cath lab. A guy, you see the big ST elevation? They're in there, they put the balloon up, elevation goes away. Balloon down, elevation comes back. And they're looking for the right place to put the stents. Pretty cool. So this is that guy's heart cath. So he actually had a circumflex that was pretty occluded. This is pre-cath. You can see it kind of comes down. There's nothing. They put a balloon in, inflate it, put a stent in, and we got pretty good flow. And it wrapped around, it actually covered the right side of the heart. So things we do in the hospital for this guy when he gets to us, we ensure he had an aspirin, a full dose aspirin. If a patient comes to the ER having a STEMI from EMS and y'all say, I gave him an aspirin, I'm content with that. I don't give them another one. If they come by a private vehicle and they tell me they took an aspirin before they got to the hospital, I don't trust them. The lay people think an aspirin, a Tylenol, a Motrin, a Lortab, they're all the same, and they're not. They need an aspirin, right? So I'd advise you do the same thing. If you get on scene, patient's having a chest pain, he said, I took an aspirin a few minutes ago, I don't believe them, right? It could have been Tylenol. Risk to benefit, 2 aspirins won't hurt you, but no aspirin can. So aspirin's very important for these folks. Once he goes to the cath lab, we're going to give him more antiplatelets. We give him a heparin or a drug called Brilinta, and that just kind of makes it where once we put that stent in, the body's response is to throw more platelets and cells to kind of fight that thing and try to clot it off, and we don't let the body do that, so we keep good blood flow. And they usually stay on the blood thinner or antiplatelet at least for a year or so. There are hospitals now that are acquiring the title Certified or Primary Heart Attack Center. I think that's the fancy name for it. And the benefit to that is now they're going back and looking at pre-hospital records. So now they have to report first patient contact, dispatch them on scene, right, to cath lab. So in the past at the hospital, we had 10 minutes to get an EKG, 90 minutes to get into a cath lab, right? Those times are being pushed out to EMS. So it's going to make more of a strain on us. But the good news is it's going to make the hospitals more reliant upon us and our documentation. So hopefully we're going to get data exchange and they get more buy-in with EMS. So we've already seen at UAB a pretty large increase in cardiologist involvement and wanting to be involved in pre-hospital care. And I haven't seen that in years. So it's nice. Yes, sir. Yep. Yes, right. And that stuff makes cardiologists just giggle. I mean, they like those numbers, right? So very important stuff. It's going to move us a lot better in the future as far as relations between hospital and pre-hospital. This is just that kind of diagram that kind of shows you. Normally you think inferior stuff is off the right coronary. Some people have a dominant circumflex and that wraps around the heart and provides the right side too. if the guy did have a big right coronary infarct, not a circumflex, and you're on scene, you give him some Zofran, you give him some aspirin, and then you pop a nitro, and now his blood pressure goes to 70 and his heart rate drops to 40. What are you gonna do for that guy after you cuss? Yeah, give him some fluids, right? So he's got a right ventricular infarct, right? So he's very preload dependent. We just knocked it out. So laying back, give him some IV fluids, maybe a whiff of atropine, okay? Or maybe just the fluids, but cool. People say you cannot give people having inferior STEMIs or right ventricular infarcts nitro. You can. Just be advised that if that happens, you got to fix it, right? If his pressure was 90 systolic to begin with and heart rate was 50, he doesn't get nitro. But if he's hypertensive and normal and heart rate's okay, and you try it, no harm, no foul. Just be prepared to fix it if he drops his pressure. All right, this is too fast, too slow, or okay. I'll say the rate's okay. Machine says 60. I'll say 300, 150, 100, 75. Yeah, 70-ish. All right, so 1 AVL, 5 and 6, 2, 3 in AVF, V1 through V4. I look at AVR, 1 and AVR are pointing the opposite direction. I go back, I look at my PR interval. It looks reasonable. My QRS, a little bit wide. So I go over, I look at V1, I'm pointing down, I have no Q wave. So this is a left bundle. So machine's really not going to interpret these for you. So now it's up to us. Is this STEMI or no STEMI? STEMI, very good, yeah. Yes, you always want patient history. I agree. Because there are some people who have a jacked up EKG all the time. So if he's smoking a cigarette with ankle pain, it's probably not a STEMI, right? But the EKG with no clinical data, I would say, yes, it is concerning, right? So remember, discord is good. So this is reassuring here, opposite direction. It's elevated, but not more than 1 big box. That's okay. But when I start my initial look at leads 1, AVL, and 5 and 6, this is concordance. That's ST elevation. That's enough data that, nope, this is a STEMI. I need to talk to somebody about this guy. So now this guy's a critical patient. We go through our aspirin, our nitro, our oxygen, as we talked about, defib pads. We get early intervention at the hospital, however you send these, whether you transmit it from the machine or you take a picture or you draw it, whatever you, that's a joke, don't draw it. But, however you get it to the hospital, they need to know that, right? The patient also gets a better history. You expose them and you start asking questions that risk stratify your management. So now I'm going to say, I've already got the history of heart disease, maybe diabetes. Now I'm going to double check medicines they take. Do you take Viagra or Cialis? And I'm not going to ask them that in front of a crowd of people because nobody's going to answer you that question, right? All right, you lean down, you whisper, you ask those questions. That may determine, do you give them nitro or no nitro? Drugs, I don't care if they smoke weed or not, or shooting up heroin, doesn't matter. If they've been doing cocaine, I like to know that because they're hypertensive with this. I might give them a little bit of a benzo, a little bit of Versed or something to help them out as well. Cool. I was going to say, what tool do we use to figure out left bundles? And that was a hint. Scarbosa, isn't that Scarbosa from some cartoon or something? Maybe not, no. All right, I'll keep moving. All right. Fairly inappropriate humor. I meant to bring about 25 pig trachs today and only 5 showed up. So we got pig trachs for later for airways, not rectums. So that make you feel good. You said you got hungry? What'd you say? Okay, yeah. Yeah, boneless. Yeah, no comment. So this is a guy just hanging out in the ER that they had having a dysrhythmia every now and then. And so we put him on the 12 lead to kind of capture it. And we're just running a rhythm strip and he went into this rhythm and said, I don't feel so good. What is that rhythm? Yeah. I guess the first question, normal or abnormal? And I would say this is normal and this is abnormal, right? So VTAC. So how do you manage VTAC? What questions do you ask first? What does American Heart say? Are they stable or unstable, right? In reality, I'll say they're probably all kind of unstable, right? My question is, do they have a pulse or not, right? So obviously the guy's got a pulse talking to us. What are our treatment managements for this? What can we do for this guy in the field? What did you say? Shock, yeah, I like that. Electricity. Do you defibrillate or cardiovert this guy? Cardiovert. man, y'all don't even need me. This is cool. Let's say that it takes a few minutes to get to your monitor and you wanted to try drug therapy, or you had a ridiculous ER doctor that gives you orders over the phone and says, don't shock him, do drugs. What drugs can you give this guy? A little bit of lidocaine. You know the dose of lidocaine, anybody? Yeah, 1 mg, 1.5. I usually give them a box. That's probably not good math, but I give them 1 box, right? See if that works. What's the other drug you could give? Yeah, and what's the dose of amio? Perfect, yeah. And how do you push amio or give it? Yeah. So I think the protocols in our state say you put it in a 250 bag and run it over 10 minutes. I can tell you that I usually put it in a syringe and push it over a few minutes. Just food for thought.
I can tell you that the least done procedure in the field is buzz of a waiting patient.
Yes, right. It is. So the way I look at that is, so in my mind, I sedate anybody I'm going to use electricity on. Either I sedate them or they're self-sedate. So if that guy with that rhythm has got a blood pressure of 100 and he's talking to me and doesn't feel well, if I synchronize cardioverting him, he's going to call my mama names, right? So I'm going to sedate him. If his pressure is 70 and his eyes are rolled back in the back of his head, does not matter. He's already sedated. He does not need drugs, right? He's sedated because of poor perfusion. I'm going to synchronize cardioverter him. So that's the way I look at that. I think we have to call for orders to sedate in the field. That's reasonable. Ketamine is there. Versed is there. Fentanyl is there. That doesn't sedate you, but some people still use it. Just talk to your medical director about what you want to do with that stuff. But I'm the same way. If they're awake talking to me, I'm not going to just zap them. They don't appreciate it. I mean, I do. It's kind of funny, but they don't appreciate it. So I had some cool pictures about synchronized cardioversion, but y'all are way too smart. I didn't even get to get my pictures and use them. Cool. Do I? Yeah. There was a young fella in North Birmingham, 38-year-old guy, called by family. He was apneic. They said they were doing CPR. When EMS got on scene, he was in VFib, right? So they threw him on the Lucas device, start CPR. I believe in early advanced airway management for these people if you have enough crew members. Blind insertion devices are fine, but if you have enough people and you can intubate while you got CPR going, that's what I recommend. So a guy got intubated, got a dose of amio, got a defib, and they got a pulse back. But he's 38, so what's going on with this guy? So when I think about VFib arrest, I think about 2 things that cause it. One, acute ischemia. So guy's got bad heart disease, has a big STEMI, goes into VTAC, VFib. Those guys should always go to the cath lab, evaluated even when you get ROSC back, right? There's another reason for VFib arrest too, and that's structural heart disease. Somebody has bad heart failure, congenital defects, cardiomyopathy, things like that. They're going to VTAC or VFib pretty frequently on you as well. They're just kind of hanging out. All of a sudden they go into VTAC or VFib. Management is the same on the field, but the hospital management is different. So this guy got ROSC back by pre-hospital, comes to us, his lactic acid is like 10. He's posturing, looks like he probably had an anoxic brain injury, but doesn't matter. He's 38, there's a hope for this guy. So we put him in hypothermia and he goes to the cath lab. His 12 lead was completely normal, but he still goes to the cath lab. Had a clean cath. Come to find out this guy had been using stimulants for a while and had cardiomyopathy and a big heart and just had a run of VFib that we happened to catch. The good news is with appropriate therapy, hypothermia, he actually left the hospital about a week later and walkie-talkie. I guess you can't say walkie-talkie, but he was alert, able to go back to his job, okay? You know, the things that you do in the field make a big difference. EMS does more codes than the hospital does. You guys run all those things. It's easy to get lax on those things sometimes, but you know, if you do a good job, sometimes you can get somebody and have a long life. That 38-year-old guy, I mean, he's got another 30 years of life left in him just because of what that EMS crew did in North Birmingham. What questions or comments you got for me within reason? Y'all make me nervous. You got good questions. You already know all the answers, so I don't know what to. Any questions online, Chief? All right, we'll take a 5-minute break. we'll let Dr. Eversull come. And then I forgot to tell you, for those of you that interact, I got knives, coins, coupons for free beer. Coupons for free beer. That's funny. Yeah. Yeah, I know. I should have told them that before, but.
Hey, for everybody online, please remember to fill out an attendance form. You can either click the link in the chat box, or you can send an email to alabamaemschallenge@gmail.com. You'll get an automated reply with a link to the attendance form, one attendance form per person, please. And even if you don't need the Con Ed, please take a couple minutes, fill it out so we can get your feedback and get an accurate attendance. And we will be back here in just a few minutes. All right, everybody, we'll get started back. Got Dr. Eversull who's going to be talking to us about non-ACS chest pain.
Can you hear me? Perfect. We're sharing now. Good deal. Thank all y'all for coming out this morning. You know, with COVID and everything last year, it's really nice to be in front of a room full of people. So thank you guys. Also, just want to say thank you to Mobile Fire. Thank you to Chief Lamy, and special thank you to Chief Cox for doing a lot of the legwork to get us into the venue today. We're going to be talking about non-ACS chest pain, and I think we have to talk about what we're not going to talk about. So we just have to address ACS real quick, acute coronary syndromes, which I know Dr. Ferg just did a great 12-lead review, and we talked a lot about, you know, STEMIs, InSTEMIs, unstable angina. That's the last time we're going to talk about that for this lecture. So these are all the things that we need to know about when someone has chest pain, and we've kind of ruled the other stuff out. I know that pretty much everyone is here has seen someone with chest pain before, because y'all done this for more than a day. Chest pain has consistently been like one of the top 3 calls for 911 for EMS, and then that we see in the ER as well. And it's been that way for quite some time. It's not going to slow down. So these are people that we're going to see all the time. The purpose of what we're going to talk about is just to expand that differential and get past ACS and get into like the 6 things that are going to kill you or cause you a lot of harm if you don't pick them up. Okay. Y'all stop me at any point if y'all have questions about any of this stuff. All right.
Hey, Doc.
Sorry.
We did actually have a couple of questions come in during the break.
Man, we just started. I'm telling you.
I know.
Okay.
So most of them are centered around amiodarone for VTAC with a pulse, asking why do we have to give it in a drip? Is it just to prevent hypotension, or can it be pushed, or? Yeah,
so the way that it's written is that first 150 is supposed to go in over like 10 minutes as a drip. And then I think the second 150 runs over like an hour. Is that right?
So I would just do the initial infusion. So the 150 over in 10 minutes. I would not do a drip on anybody for anything.
No, yeah, not in the field.
Most cardiologists are not going to do a long-term amio drip. They're going to look for other reasons to do that.
Yeah.
I push the stuff in the ER, so I draw mine up in 10 or 20 mils of saline and push it. So maybe that's something we can address in November and make it where we can just do that.
Yeah, we had some questions too about, so there's been some conflicting information over the years since we started using amiodarone about the equipment that's required to create an amiodarone drip. I think Dr. Ferguson and I have talked about this in the past, but a lot of the early literature especially said that you would form a precipitate if you used the standard equipment. You needed a filter and you needed a special material for the bag. And so people are just asking, is that a concern? Is it not a concern? Do we just push it? And I think my answer is you just push it and push it really slow. Push a little, wait a little. Is that good advice?
I think that talk to your medical director and see what they're comfortable with and go from that route. Again, I push it in the ER. So, yeah.
We're good? No, we're good. What's that? This is the chest pain protocol that we all know and love. It's straight out of the protocol books here. We get a call for chest pain. We go out to where the patient is. We are getting an IV. We're supporting their vitals, and we're getting a 12 lead, like Dr. Ferg said. And that's what we're looking for is ACS. And that's really what this protocol is designed to do, is to evaluate for ACS, okay? All the meds and the pathway that this follows all treats ACS chest pain. So when we get them on the monitor and they say, "Doc, I don't feel good. I feel like something is crushing my chest. Something's ripping inside of me," and they're diaphoretic, but they don't have ST elevations. What next? Like, does that person just stay there? You're like, "Oh no, this is not ST. This is not STEMI. You can stay here. Do you bring them to the hospital? Like, what's your thought process?" And that's kind of what we're gonna go over today. So we're not gonna cover every single thing that's gonna cause chest pain because that list is crazy long. These are the 6 things. I've tried to distill this down, right? These are the 6 things that if you don't pick up are gonna cause this person a lot of harm. It's either gonna kill them or they're gonna have a high morbidity from it, okay? So we're not going to talk about pneumonia or chest wall bruises or, costochondritis, any of this other stuff that causes chest pain. This is just the stuff that's going to kill them. This is the stuff that we can't miss in the ER, okay? I tried to group these together to make them make sense. So I tried to group, pulmonary embolism and tension pneumothorax, like lung pathology. I tried to group that together. And then I tried to group the vessel pathology together, and then I couldn't find a good way to group cardiac tamponade and esophageal perf, so they're just there. Before we start getting into our list, I wanted to do a quick path review on really kind of what chest pain is and why patients experience chest pain and describe it the way that they do. So there's, very simply, there's 2 types of nerve fibers that we're going to talk about: somatic fibers and visceral fibers. Somatic fibers take information from our skin and bring it back to our brain. That's how we perceive the world around us. That's how we feel, smooth, rough, hot, cold. Those fibers are going to travel back into the spinal cord and enter at a single level. Because they do that, we can map out the areas that they innervate into this dermatomal map. Have y'all seen this before? Yes, no? Perfect. So we can map these areas out, and because we can do that, pain from these areas is easily localized. If Dr. Ferg gets mad at me and throws the microphone and it hits me, I'm going to be able to localize where it hits me pretty quickly without a problem. That's the way somatic fibers work. Contrast that with our visceral fibers. These are the fibers that innervate our organs, and they tell our brain what's going on inside of our body. These are the fibers that innervate our heart, our lungs, our esophagus, our blood vessels. I mention those specifically because those are the things that we're going to be talking about for the rest of the lecture. But if y'all can see this, these guys, they enter the spinal cord at multiple levels, which means we can't map them out. And so if you have a problem with your trachea, it's going to come in and run into any of these levels, and there's some cross reaction with the somatic fibers there, and that's why we get radiating pain. So that's why you get that pain that shoots up to the shoulder or down the left arm. Does that make sense? Questions about that? Cool. All right. We'll jump in. We'll get started with PE. I remember as a medic, we'd run these arrests in the field, and these people would die. We'd never get them back. And we would always speculate kind of after the call. We'd go, I wonder if they had a big PE or if they had if they had a heart attack. We just never knew. And I never really knew how common they were. And so just a few kind of facts about pulmonary embolism. It's the 3rd most common cause of cardiac death worldwide behind heart attack and stroke. It's the leading cause of preventable hospital death. And almost a quarter of these just present as you're dead, no symptoms, and then dead. I thought that was pretty scary. So I think kind of thinking back, when I think about those, out of hospital arrests, probably more than I gave credit to were as a result of like a pulmonary embolism. So what is a pulmonary embolism? In short, it's a blood clot in the lungs, but it's also known under the more broad term venous thromboembolism. And that's this umbrella term that basically says there's a big clot in a big vein somewhere in the body. It's just a fancy word for saying a big blood clot in a vein. And that includes a DVT, a deep vein thrombosis. Typically, these are going to happen in the larger veins. Your body is constantly making clots and breaking them down all the time. That's part of what your body does. when you get these big clots that form in the big veins, the veins in the legs, the veins in the pelvis, in the axilla, those are the ones that we worry about the most, although they can happen in any big vein. You get these big clots that stick to the wall. Now, they can do one of two things. They can either grow in size, so they can be broken down by plasma and get smaller. If they grow, then big chunks of this thing can break off and travel up through the venous system, through the right side of the heart, and then through the pulmonary arteries. As those arteries start to branch and get smaller, they can get stuck. And that's where you get your pulmonary embolism. And y'all can see this was a cadaver picture. I don't know if that's what killed this person, but I'm assuming that it didn't help them because their lungs are cut open and there's a clot here. But this is just a big saddle pulmonary embolism, and you can see that there's no blood that can get downstream from this. So all of the capillary beds that were supposed to be perfused by that lung, by that capillary bed inside the lung, they can't do that anymore. So there's two problems here. The first is that you have a perfusion defect, so you're not oxygenating the blood that's coming through that part of the lungs. And the second thing is that if you have a clot big enough, the right heart is too weak to pump through that clot. And so you get acute right heart failure and you die. So those are the two kind of mechanisms that cause problems when you have a pulmonary embolism. Because these clots can be huge or they can be small, there's a huge variation in the people that we see and in the patient presentations that we see. And that's why it's so hard. And I think, Dr. Mack, you've been doing this a lot longer than I have. I mean, there's an art to trying to figure out who has a pulmonary embolism. It's not a simple thing. There's not just an easy algorithm that tells you, oh, it's definitely this patient. There's not a single thing in the history. There's not a single thing in the physical. There's not a single thing that these patients consistently present with that would go, oh, I think this is a PE more so than something else. And so the real thing is trying to figure out who has it. It's really, really difficult to pick out of a lineup. I saw a review, Roger Ebert's worst mover reviews. Apparently he gave The Usual Suspects like 1 star. I don't know. So when we are trying to decide who has it, we're looking for clues in the history and in the physical that would help us kind of point in that direction and raise our suspicion that maybe this is a pulmonary embolism. Again, there's not a single thing, because you can see this list like tachycardia. Tachycardia is the most common EKG finding. How many patients do we see that have tachycardia that certainly don't have a pulmonary embolism, that are here for something? Tons, right? Tons. And that's one of the difficult things about this. So the most common physical symptom is just a fast respiratory rate. Just a respiratory rate more than 20. Tachycardia is questionably the most common EKG finding. There's a question as to whether or not non-specific ST changes are the most common EKG finding, but neither one of those things really help you, So there's some changes on the EKG, they're non-specific. They're tachycardic. Right heart strain on EKG, there's some right heart strain patterns. I know Dr. Ferg talked a little bit about right bundle branch blocks and some things, and we'll see an EKG here in just a second. And then unilateral leg swelling is a thing that you could find on your physical exam that might lead you to think, oh, maybe they have a DVT and subsequently a pulmonary embolism. So EKG. Has anyone heard of S1, Q3, T3? This is not something I heard about as a medic. This is not something I knew as a medic. So it's a right heart strain pattern on the EKG. So if you look at lead 1, you have a big negative deflection, this big S wave right here. Normally you don't see this in lead 1. So S1, and down to lead 3, you have this Q wave right here, and inverted T waves, S1, Q3, T3. And this is just, again, it's not specific for pulmonary embolism, but it's one of those things where I think it's something like 18% of people that have a PE that have EKG findings will have an EKG that looks like this. And so it's not a normal EKG because you notice the T wave inversions, but this is that S1, Q3, T3 pattern. So it's just one of those things that if you see should raise your suspicion that, this could be a pulmonary embolism if for whatever reason their chief complaint isn't otherwise explained,
Hey, Doc, how common is that sequence of findings for any right bundle branch?
This, I'm not sure about for any right bundle branch. You know, any kind of right heart strain can create, you know, that widened QRS and that right bundle branch pattern. And that's certainly, you know, you're certainly going to have right heart strain if they have a PE big enough to cause some obstruction. I don't know how often it shows up though. I don't know what the percentage is. Is that what they're asking? Yeah, I'm not sure. It's one of those, it's not 100% of the time, certainly. It's less than 100% of the time. I think the S1Q3T3 is, you know, maybe a fifth of the time.
So this finding could exist with or without right bundle branch.
Correct.
clot.
Yes.
I think that's
Yeah.
the question.
Yeah, and that's kind of the theme for pulmonary embolism is like all these findings could exist with or without a pulmonary embolism. Like these things could be explained by pulmonary embolism or they could be completely explained by something else. So it's really hard to pin this down.
Yeah, that's like the question that you asked earlier about clinical presentation. That's when it really matters because you got a large population of people will have that EKG finding and may not have any symptoms whatsoever. So you got to put it with the clinical situation.
That's right. You'll notice anything on this picture? Positive arrow sign? What's that? Yeah, yeah. So you got a big fat leg. If they have unilateral, so just one leg is bigger than the other, you know, and these CHF patients that we see, you know, we're used to seeing both those legs be big and swollen and fat. If they just have one big swollen fat leg, that should raise your suspicion for a DVT. They could also look like this and have cellulitis or thrombophlebitis. So like there's other things that explain this, but if you see this and they're not short of breath and I'm sat 80% and my chest kind of hurts, you know, your suspicion for a PE should be a little bit higher at that point. Things that should help kind of clue you in when you're doing your history. There's genetic acquired and then these kind of transiently acquired conditions that can also raise your risk of having a PE. Again, this is probably half the population. So oral contraceptives, pregnancy, being old, being fat, having chronic disease. Obviously anything that increases clotting in your body. So any of these genetic factors are going to increase it. I think the biggest one on here is cancer. I think if this patient has an active malignancy, it increases their risk by like 17 times of having a pulmonary embolism. So you have to take all this information and put it together to decide kind of how high risk are they for having a pulmonary embolism. This is not for you guys to memorize. This is just an example of the pathway that we kind of think through in the ER. So once they get there and you go, doc, we've got this guy, he's got this chest pain, he's got unilateral leg swelling, he's a cancer patient, he recently had surgery. You know, I'm gonna go, oh, you know, I wonder if this guy could have a PE. Not everyone who has the symptoms that we talked about needs to be worked up for a PE. So that workup includes a CT angiogram, and if they have it, then it includes the treatment is going to be anticoagulation, which has high morbidity. The workup itself takes time. It takes time to get someone into a scanner, and a scanner has the risk of, you know, you're radiating this patient. So there's harm that you can do with this stuff. That's why we just don't do it to everybody and scan everybody on the way through. So all of this starts with just assessing your pretest probability. Do I think this person has a PE based on the history and the physical that I've got so far? And then this is just an example of one pathway that we would use to kind of look and make these decisions about whether we're going to work this person up or not. Make sense? There are several decision-making tools that we use that I looked at and realized that you can do these in the truck. Like none of these require diagnostic stuff. I mean, this is all just things that you get on the history and physical. What I like to do, this is the Wells score. The Wells basically takes them and risk stratifies them. They say this person is low, medium, or high risk for PE based on the score that you put in right here. If they are low risk, then I like to add the PERC rule. It's the pulmonary embolism rule-out criteria. And if the answer is no to all of these, then I don't have to test this person at all. I don't have to move forward. I can say the risk of this person having a PE is less than 2%, and it would cause them more harm for me to go after this and test for it. And so it's a good way to not necessarily rule it out. It doesn't mean that they don't have it. It's just that there's a less than 2% chance that they do have it. Obviously, if they're anything other than low risk, ideally we'd like to get that CT angiogram, which we put contrast into their vessels and it shows us if there's a clot in the lung. The problem is even that's not 100% specific. We're not always going to get an answer every time we do that. You know, some other options are look to see if they have a DVT with ultrasound. You're going to hear me harp a lot probably about ultrasound as I go through this lecture. But that's one of the things that you can do. And if you see a DVT on ultrasound and they're having symptoms of a PE, you can stop. You don't have to go any further, and you can presume that they have a PE. That person will get anticoagulated. So anyway, that's the pathway to PE. Any questions about PE? That's kind of the most sort of complex, vague one that we'll cover.
Yep. So we got a
Yeah.
couple. One is you had hemoptysis listed as a sign, and the question is what's the mechanism for blood to be coughed up with the clots in the vessel?
I think that just winds up being vascular congestion that backs up into the that basically bleeds out third spacing. That you wind up coughing up. The most common cause of hemoptysis is not pulmonary embolism. So not everyone with hemoptysis has pulmonary embolism. In fact, I think the most common cause of hemoptysis is just like a bronchitis. And they just cough and cough up blood. And that's just irritation from the airway tract. But I think the PE is more of a third spacing in vascular congestion that leaks out.
And so the other question was is there a huge risk to the anticoagulation if there's any suspicion?
Yes, so there's a lot of morbidity that's associated with anticoagulation. And like Dr. Ferg said, you know, about half the population is probably anticoagulated. All these people are anticoagulated, but it carries a much higher risk for things, you know, hemorrhagic strokes, and it rules them like if they have a stroke, then you can't give TPA if they're anticoagulated. And, you know, obviously there's a huge increased risk of bleeding. So there's morbidity associated with it. That's why we don't just throw this stuff at everybody kind of willy-nilly. We've really got to think about who we're doing it to. Anything else?
Yeah, so we have high suspicion for PE.
Mm-hmm.
Just alert you as quick as you can and get it there as quick as you can.
Yeah. I mean, support their vitals, high flow oxygen, you know, because there's a perfusion portion of this, and then there's a cardiac portion of this. So you can give them some fluids to kind of help support that right heart, but you can give them some oxygen to kind of help that perfusion deficit that they may have as well. But I mean, ultimately they're going to need, you know, in the future, as ultrasounds get on the truck more and more, it would be a quick thing to look for a DVT, and that would be helpful information coming in. The gold standard is still a CT angiogram. You know, it would still be great. You know, I would love for you guys to roll in and be like, this person has a DVT and they're setting 82% with chest pain, and I'll go, oh, that sounds like a PE. You know, because it makes that diagnostic workup so much shorter. But the treatment we can't do pre-hospital. They're going to have to come in and see, you know, a provider and get anticoagulated. Yeah. Mm-hmm. Yeah, absolutely. Yeah, absolutely. You could have a unilaterally swollen arm. And it's not just those veins, like there's a big vein that leaves your spleen that you can get clots in. And obviously, what do you do for that? I mean, you can't see that. And that's why you can have these symptoms in the absence of any kind of arm or leg swelling. You could have a deep vein clot that's, you know, in the abdomen that you don't see any like physical manifestation of. Makes sense? Yeah, great question. All right.
So we had one more question.
Go ahead.
Any value to giving aspirin pre-hospital?
Any value to giving aspirin? I hadn't thought about that. I mean, the I don't know. Go ahead, Ferg. You have. Oh, thought you had an opinion on that. I don't think it would hurt them. It's not in any of the algorithms to treat them. You know, the clot's already there. It's a clot that traveled from somewhere else.
Yeah, I'm like you. I don't think there's no risk to the drug. It may not be a benefit. I give them the aspirin in the hospital before I start other blood thinners such as heparin or Lovenox. So there's really no risk. So I would say it's reasonable to do that. And you can tell that with pulmonary embolism, they could have almost anything going on, right? They could have bronchitis or pneumonia. They could have cellulitis. So you got to put the whole picture together. So I'd say, the key to treating is diagnosing it. And if you're concerned, when you get to the hospital, tell a doc why you're concerned. Say, hey, I got this girl who's got a swollen right leg. She's smoked. She's on birth control pills. She's hypoxic. She may have a PE. And that should make any reasonable ER doc get up and go see that patient, because that should be a red flag for us.
Yeah.
Now, if I got somebody come in and saying they're PERC positive with a well score or something, I'm like, I got to Google that because I don't use that a lot of stuff, right? I may not move as quick, but if you come in and you approach me and you're concerned about this patient, you say, this is what's going on, I'm going to go see her. And maybe she does have cellulitis or heart failure and now short of breath. But if you tell me PE and give me enough reason, I'm going to get off my chair and go see them right then. And that's how we manage these people, is we diagnose it. So you got to find it first.
And in the context of, this 911 call, this is chest pain, right? And so there's a good chance you're going to give this person aspirin anyway. So, cool. Any more questions? All right. Tension pneumothorax, I think a lot more straightforward. I think this is something that we learn about in medic school. And, this is one of the H's and T's that we're going over and we're thinking about when we're doing our, out of hospital arrests. The physiology here is that you're essentially getting air in between the lung tissue and the chest wall. It's just kind of a one-way valve. So every time the person breathes in, you're getting a little bit more air that builds up, kind of like blowing up a balloon. It's going to compress the lung tissue. And if you can see in this chest x-ray, I know you guys don't get to see chest x-rays in the field. This is just black and clear over here. And you see how this is kind of fuzzy and white, patchy over here. This is normal lung. This is where lung is supposed to be. So this is the pneumothorax over here. This is where the lung is now. It's been collapsed down. So obviously when we drop one lung, we're going to have perfusion problems. But the bigger problem here is that as the pressure in that side of the chest increases, it gets high enough that it can collapse the IVC, which has relatively low pressure. And once you do that, that's the definition of obstructive shock, because you can't productively move blood forward anymore. So that's what's going to kill them eventually. The big clinical features to look for are the absent lung sounds. That's the one that always gets hit in the paramedic books, absent lung sounds on one side. And then you've got to decide if it's a pneumothorax or a tension pneumothorax. So if they're hemodynamically unstable, then you have to presume it's tension. You have to try and correct it without any other test. They can have hypoxia, and then this is like plus or minus. Like I remember the big thing was like, oh, you have to have tracheal deviation. And this X-ray does have a little bit of tracheal deviation. But that's a late finding. The pressure in the chest wall has to be high enough to move all the mediastinal contents over. So ideally, we would like to fix this before we get to that point. And then obviously tachycardia, JVD, plus or minus chest wall trauma. So this doesn't always have to happen because of trauma. We see spontaneous pneumothoraxes all the time. I had a weightlifter the other day that was doing something and was like, oh, I think I pulled something. And he was getting ready to go to the beach. And so he wanted just to come in real quick and get checked out. And about half of his lung was down. So they don't always have to have trauma to suspect this. But obviously, if you do have like a trauma to the chest wall, this would certainly raise your suspicion. Again, I'm going to talk about ultrasound a lot, and I know that you guys probably haven't seen. Has anyone seen this? Is anyone familiar with Dr. Max cheating? Has anyone else seen this at all? Okay. So this is an ultrasound probe that has been taken in place just over the rib, over the chest wall up here. Okay, it's a linear probe, and what we see right here, this is just skin and soft tissue. This is a rib. And this is a pleural lining, this little white stripe, and this is another rib over here. So we're looking in between rib spaces down to lung. In real time, we see this motion down here, and this is just plotted. This graphic plotted over time, okay? I don't want to make it super complicated. What we should see in a normal lung, you see how this kind of looks like sand and this kind of looks like waves, like you're sitting on a beach? Yeah, this doesn't look like that. I got a couple of nods. So this is normal. This is what we should see. This is the pleural slide. So this is that saran wrap layer kind of over the lungs and the chest wall. This is what we should see. Normal lung here. If I throw the probe on and it looks like this, I don't have normal lung. I've got a pneumothorax under there. It doesn't tell me if I have a tension pneumothorax. Again, that's clinical, but it does tell me that I have a pneumothorax. Okay. Not every pneumothorax needs to be treated. Not every single pneumothorax needs a needle in the chest or a tube in the chest. Okay. There's patients all the time that we get that we go, oh, they have a small pneumo, and we just watch it, and a lot of times it'll get better on its own. We'll get another chest x-ray in a few hours. If it gets worse, then we decide if we need to intervene or not. Okay. If it's big enough, we'll go ahead and intervene right away. But certainly out in the field, this would be a really useful tool because it's not always easy to listen to lung sounds in the back of the ambulance. You know what I mean? Especially if it's a trauma patient, you're doing a million other things. That makes sense? Cool. I think this will be a helpful tool in the future. So like we just talked about, treatment for this is to put a needle in the chest, right? And the classic teaching is to do the mid-clavicular line at the second intercostal space. I think these fail sometimes because people tend to go too lateral, but you also don't want to go too medial because you get into the cardiac box and you get into some high-value real estate right here. I wanted to take a point here just to remind everyone that when we're doing this, needle goes in and it has to go over the top of the rib. What we want to avoid is hitting this stuff right here, which runs underneath the rib. So I like to go in, basically hit the bone with needle, and then physically lift up and then push over the top of the rib to get it in. The problem is that in our current population, the 4.5 centimeter needles we use will work in maybe half of those people at best. So we need some harpoons. So what do? We do what the military does, and we can look at the mid-axillary line at the 4th or 5th intercostal space. An easy way to get there is to use the patient's hand, not like someone with these giant tomahawk steak hands, but just the patient's hand, put it in their armpit, and that should put you right down here in the 4th or 5th intercostal space in the mid-axillary line. There's a lot less meat right there, and so it's easier. The chest wall is a little more exposed. The problem is that once you put their arm down, you'd have to transport. Now you're managing this catheter that's sticking out of their chest that can get knocked out of place. But this is the military's go-to in the field because they've got their body armor on, and those guys have, thick chest anyway. They can throw an arm up and put a needle in really quick.
Hey, Doc, is there a danger of going too high?
Yeah, so are you talking about too high in the anterior chest?
Actually, in the axillary. Is it better to go too high or too low?
So this green triangle here, this is the triangle of safety. I did not name it that. But as long as you're within this triangle of safety, it's pretty safe. As long as you're going into the chest wall, you've got the brachial artery and the subclavian, that branch right through here. But if you stay above the nipple line and this pec muscle is the other border, if you stay in that triangle, that's a relatively safe place to be. I think it's a better place to be than being inside the cardiac box. I mean, there's a lot of high dollar real estate right here in the cardiac box. So as long as you don't, angle it up and stab them in the subclavian or the brachial, it should be fine if you go through the chest wall right there. Yeah. Make sense? Any other questions? Once you do this to someone in the field, you commit them to a chest tube on the way, like in the hospital, which is probably one of the most unpleasant things that can happen to someone. So just know that, I would be sure that, they're hypotensive and you're worried about this tension before you just stab them in the chest. You may need to do this more than once as well. All right. Any other questions about tensions before we move on? All right.
So I'm going to say one thing about that as well. So when you think about a tension pneumothorax, we always think about trauma, but remember, when you have a firefighter doing CPR on a 60-year-old, 50-kilo female, that's trauma too. So think about that in your medical arrest, that if you get in the back, you get ROSC, and all of a sudden now they're hard to bag, their SATs decrease, and they go into PEA. Think about tension pneumothorax there as well. So tension pneumothorax, you got to have a pneumothorax, like you said, then you got to have tension. And I define tension as they're dead. That's tension. The other way to define dissension is ultramental status and poor perfusion. So ultramental status, signs of a pneumothorax, ultramental status, and now I had a radial pulse, now I don't, I just have a carotid, and that might be enough. I'm not going to spend 10 minutes trying to get a blood pressure if I know they have a pneumothorax. Does that make sense?
Mm-hmm.
Cool. So there's no risk to doing hemodecompression with somebody with a tension pneumothorax. The risk is that they don't have a tension pneumothorax.
Cool. Vascular pathology. This was something I did not feel like I learned when I was in medic school. Aortic dissection and carotid dissection are, the pathology is the same for both of them. So we'll talk about pathology first for aortic dissection, and then we're just kind of briefly going to hit the carotid dissection. This was something that I feel like maybe took me a little bit longer to sort of conceptualize and understand well. So in plain English, you've got an artery, and it's got 3 layers. Okay, you got an inside, a middle, and an outside. They've got fancy medical names that we don't need to worry about. But what happens when you get a dissection is that the inside layer is cut. It's open, and the high pressure blood from that artery is going to separate either the inside layer from the middle layer or the middle layer from the outer layer, and it's going to create this big false pouch all the way down the vessel. Do y'all see that? Does that make sense on here, how that works? Okay. It took me a long time to figure that out. I don't know. Y'all are smarter than me. The way I think about this is chest pain plus. So this is someone that's going to go, oh my gosh, I had sudden onset ripping chest pain. And a lot of times these people are going to have some other symptom that's not explained by just ACS. Like, we know ACS pretty well. We see that all the time in the field. We're trained to think about that. That's like what we reflexively think of when we get a call for chest pain. This is chest pain, and you get there and they're like also having a stroke. They're like, I have chest pain, and they can't move this arm. And you go, man, what the heck is going on here? So these calls come out as like strokes. This is chest pain plus hoarse voice because the phrenic nerve runs down and over the aorta. So you can have phrenic nerve involvement and get hoarse voice. This is chest pain plus new signs of heart failure, like bad JVD. Something else that just doesn't explain why they are the way they are. Patients who complain of tearing or ripping pain, the probability that they have a dissection is multiplied by almost 11 times. And then chest pain in the setting of a focal neurologic deficit, so chest pain plus stroke, they're 33 times more likely to be having a dissection.
Most people think of chest pain as being anterior chest. Tearing is what they feel in their back.
Right, radiating to the back. Yep, absolutely. So why do we get these neurologic symptoms? So 2 reasons. Anytime that we cut a blood vessel and we expose the endothelium in the inside of that vessel that normally shouldn't see the light of day, it should be all sealed up, nice and smooth. Anytime we open that up, we activate the clotting cascade, right? That's how we like stop bleeding when we cut our arm. It's supposed to do that. The problem is now it's inside the vessel and it's ripped open. And so we've activated this clotting cascade. So when this happens specifically like in the carotid artery, it's going to shower the rest of our brain with these clots that are getting made because the clotting cascade is now active. The other thing is that as this tamponade, as we get this lumen, it can actually tamponade off the good blood supply to the organs that it's supposed to be going to. So these people can get like limb ischemia. And they can, they may not say, oh, I can't move my arm, but they'll say my arm, like it hurts, it tingles, I can't feel anything, paresthesias. And so you go, man, that's not typical. That's not normal. That's not what I normally hear when someone has chest pain, right? And so that's kind of what's going to raise your suspicion a little bit.
Hey, Doc, so I know a lot of the textbooks talk about getting different blood pressure findings, right and left arm.
Yeah.
How useful do you think that is? Do you think that's a useful technique?
Yeah.
And why is that true?
It is, and it's because of that perfusion deficit. And so what they typically do will get, you can feel their pulses just real quick and dirty in the field. If they have a pulse deficit on one side, it's because the way the aorta branches, if they have an ascending, so coming from the aorta, starting at the aorta, at the aortic valve in the heart and moving up, as the aorta starts to branch off into the subclavian and axillary arteries, if the dissection then runs up or occludes one of those arteries, it obviously will stop the blood flow or decrease the blood flow to that arm. And that's why you get these differences in pressure and differences in pulses. Does that make sense? Cool. This is a CT image of what we actually see when we see the dissection. This is the aorta. It comes up in loops. And you can actually see the dissection flap and then the contrast in the false lumen here. This is just supposed to be big and round. Currently, not anything you can do to evaluate for this in the field. It's my ultrasound plug again. So you get ultrasound. This is actually an abdominal. Does everyone see that? Is that pretty clear? This is the spine right here. And then you're just looking right down the abdomen. You find the aorta. The aorta is relatively easy to find in people that aren't huge, because it's a big high pressure system. So you can actually push down pretty hard. It'll compress most of the veins, but that aorta will still be big and fat, pulsatile. And so you'll be able to see this dissection flap. We had a patient that came in, this is a couple of months ago. It was an old lady, history of high blood pressure. Family said that she felt some back pain and said she was going to go lay down. And next thing I knew, she was unresponsive. And they brought her to us, and we grabbed an ultrasound probe, threw it right on her belly, and we could see this just big, massive dissection. And so we were able to start giving her, resuscitating her with blood and get her blood pressure under control. But this is certainly something that we could be more aggressive about treating in the field. There's not currently a protocol for this because we have no current way to evaluate for it. So what we do in the hospital is we would put them on an Esmolol drip. We want rapid control of their blood pressure and their heart rate. We want to take their systolics down to like 100 and 120. We want them somewhere in that range, and we want their heart rate down below 60. So we're going to hit them pretty hard with an Esmolol drip, which is a super powerful beta blocker that it's fast on and fast off. Another option is labetalol, which we are carrying on the trucks for hypertension. We can give them 20 labetalol to kind of help out. There's second and third line agents that we use. These patients are going to be old guys with long-standing hypertension or young people with connective tissue diseases. So if someone says, "Oh, I've got Marfan syndrome," and now I've got these symptoms, that should be a red flag for you. I think in the future, it's not unreasonable, if you have one of these patients, and certainly if you have an ultrasound that looks like that, if you can put a probe on them, to call your medical director and go, "This is what I've got. They've got a dissection. I've got labetalol on the truck. What do you want me to do?" I think their mortality increases like 1% for every hour that these people are left untreated. For specifically the aortic dissections, they divide it into two kind of categories. If it comes off the heart and stays in the chest, that's a type A dissection. We call thoracic surgery to do like operative interventions on that. If it's below that, below the diaphragm and down into the belly, it's primarily just medical treatment. All right, carotid dissections, pathology is exactly the same. You separate, you peel apart those layers of the artery. This is the most common cause of stroke in young people. So if you've got a young person that presents with stroke, it's likely to be something like this. Treatment also depends on where exactly the dissection is and how far into the skull it runs, and we wind up calling several different services at our hospital. I'm not sure what they're doing at Spring Hill, if there's like a one-stop shop, but we get neurovascular and neurosurgery and vascular surgery and all these people. Yeah. 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 Questions about those before we move on? Any questions on the online? Awesome. Cardiac tamponade, also one of the things I feel like we think about and get taught as medics. You've got this muscular heart surrounded by the saran wrap kind of tissue. It kind of helps lubricate the heart as it's beating in the chest. When you get a fluid collection in between the heart muscle and the saran wrap that starts to build up, you have a pericardial effusion. Not every pericardial effusion is a cardiac tamponade. It's kind of like the way that not every pneumothorax is not a tension pneumothorax. You have to have enough pressure inside this sac to collapse the right side of the heart. This can be caused by trauma, penetrating injuries to the chest, or this can be caused by other things like cancer. Patients with autoimmune disorders, will have this effusions that build up in their heart. So this needs to stay on your differential, even if it's not a trauma patient. This was a cool study that was done. This was done back in like 95 and published in one of the big trauma journals. In the study, they were looking to see if ultrasound was useful in detecting these injuries. And they found that it sort of exceeded their expectations, and it's the gold standard now for diagnosing this stuff. But what this is they had like 120 some odd patients that had penetrating injuries to the cardiac box. Have y'all heard of the cardiac box here? Yeah, so from the clavicles down through the nipples to the costal margins and over, that's your high dollar real estate in there. Anytime someone has a penetrating injury to the cardiac box, that's a big deal. And what they did was they basically took an ultrasound and they threw it on the patient in the trauma bay to see if they could detect if the patient had an occult cardiac injury. And it was really successful. It's a standard of care now for diagnosing this stuff. And so what these black dots are basically all the places that patients had penetrating injuries to the box. And then the red X's are the injuries that caused a cardiac injury that was picked up by the ultrasound. And so these are all over the place, up here, down here, not just necessarily directly over the heart where you'd think they might be. So that's the utility in using ultrasound to kind of detect this stuff. This was the teaching when I was in medic school. It was this clinical, are they hypotensive with muffled heart sounds and distended neck veins? I think half the patients I ran on, you couldn't hardly see their neck at all. It was just like shoulders and head. And then it's so hard, like, what is distant heart sounds? Like, how are you going to listen to that in the truck? Like, that's so hard to do. So again, with the ultrasound, this is a heart. This is a normal heart right here. So this is taking the ultrasound probe, moving just off to the side of the sternum and looking directly down at their heart. You have right atrium, so weak right atrium, right ventricle is not in the screen here. And you have left atrium right here. Left atrium flows into left ventricle and then out the aorta. So this is aorta. Everybody see that? Cool. This is what it's supposed to look like. This is normal. You can see this pericardial layer kind of around the heart, this shiny white stuff here. And then if you look at this, if you're watching online, I guess you can't see me. The normal heart is at the top left. And if we look at the top right, we see the same picture. So we see right atrium up here in the top, and we see left atrium spitting blood into the left ventricle and then out the aorta. And we can see this stripe that goes all the way around the heart here. Pretty obvious. So this is a big pericardial effusion. What's that? Yeah. Right. And it's chronic because it's huge and we don't see right-sided heart failure, which is what we see down here. So we see a effusion of about the same size. It's not necessarily the size of the effusion that causes it. It's how fast it accumulates. So again, we should see right atrium up here, left atrium, left ventricle, aortic outflow tract. And you see how the right atrium is kind of doing this wave motion. That's this diastolic collapse. It doesn't have the strength to basically pop back open because there's too much pressure from this effusion pushing down on it. And that's when we have this tamponade. Make sense? Cool. It's a good visual kind of representation of it. It's something that as you put your hands on these ultrasound machines more and more and more, will be very easy to pick up. What's up? When you see this stuff, you can see like diffuse ST changes kind of all over the place as it's causing problems. There's not a specific EKG pattern for it. You can see alternate. So big, tall QRS complexes followed by small, big, small, big, small, big, small. But again, it's not 100% of the time that you see it, you know? Yeah. Treatment for this is to put a needle in the heart. I think, Ferg, are some of the flight crews signed off to do that you know of?
So some of the flight crews are using ultrasound, but I don't think the pericardiocentesis is approved for anybody pre-hospital yet.
I'd heard at one point that like maybe in Alaska they were doing that stuff, and I actually got on the Alaska state website and looked and couldn't find anything in their protocols that said anything about it. So I don't know if that's just a wild rumor or what.
Yeah, I feel sure there's some flight programs, maybe fixed wing or something that would be able to do it with med control if they have training and stuff. But to my knowledge, it's not a protocol. I think once ultrasounds get more pronounced, there's a potential for that to happen.
Yeah, I agree.
I mean, I've probably seen 3 or 4 in 10 years. It's not a common occurrence.
Right.
Yeah.
The treatment for this is putting a needle into that sac and drawing that fluid off. And they may need a drain put in, or they may need a surgeon to go in and cut a hole in their pericardium to let that fluid drain out. So, not currently stuff that we're doing in the field. The last thing we're going to talk about, esophageal perf. This is not something you can detect in the field. It's not something you can treat in the field. It's difficult even for, like, we have to get diagnostic tests for this. So what is it? An esophageal perf is a full thickness tear in the esophagus. And the problem is that once you've opened that esophagus, you've exposed the mediastinum to the contents of the GI tract. So it's just ripe for infection. And that's really what does a lot of harm to these people. This can come from penetrating trauma, obviously. This can come from things that we do in the hospital to people. So like we can do like a scope down someone's throat. That's a known, pretty common cause of an esophageal perf. Or it can be from something called Boerhaave. I remember learning about Boerhaave where they throw up so hard that it actually ruptures their esophagus. And so if we have concerns for this, what we do is we give them this water-soluble, like a gastrografin dye. They swallow it and we either x-ray it or put them through a CT machine. This should just be a tube with nice lines like it is up here. And you see how it gets wispy and kind of disappears right here? So that's where the perforation is, and it's leaking all those contents into the mediastinum. That's bad. Sometimes these people need surgery. Sometimes GI says, oh no, we'll watch them and we'll check it out. You know, in the ER, we're just supporting their vitals. We're giving them antibiotics and trying to keep them from getting infected. So, questions about that stuff?
I know somebody that is up to a patient. Pacemaker replacement.
Oh, gosh. Oh, no kidding. Was it like a chronic thing? Like it just kind of worked its way?
Yes.
Oh my gosh. Wow. Wow. All right. Well, I hope that you guys expanded the differential a little bit when you're in the field and you've got these people with chest pain. That these are the 6 things that once you've ruled out heart stuff that have to be on your mind.
Hey, Doc, I did have one question come
What
in.
you got?
So today's lecture was examples of things that cause chest pain that aren't related to ACS.
Mm-hmm.
What of those things could we do harm by treating them as though it were ACS?
I'm sorry, what was the
So the question is which one of those do we need to be particularly careful about? Are there any treatments that we would normally give for chest pain that would be harmful, particularly harmful to any of these categories you talked about?
Anytime we talk about giving nitro, we're always thinking about the right side of the heart, and that's been kind of a consistent theme. You know, the right side of the heart is weak. And so anytime we're putting pressure, whether it's from a pneumothorax or from a tamponade, you know, anytime that we're going to like further kind of decrease the filling pressure of the right side of that heart, we could probably do some harm. So like Ferg said in his earlier lecture, you know, it's not a contraindication, but you should be conscious of that and look at their pressure and kind of see kind of hemodynamically what they're doing. You know, as ultrasound becomes more and more prevalent, it's going to take 10 seconds to put a probe on their chest and actually look and see what their heart is doing. And you can go, the right side of their heart is good. They have, you know, great filling pressure. Their IVC is distendable. They can handle some fluids. You know, I mean, you'll be able to measure what their heart is doing a lot better. But I would say that nitro is the thing to be careful about using if you're worried about the right side of the heart.
I'd also add, when you think about a aortic dissection, sometimes you got unequal pulses, right? So one arm will have a super hypertensive and the other arm is hypotensive. And I've seen it go both ways. I've seen people treat the arm that had the blood pressure of 220/120 with nitro, but the other arm's blood pressure was 70/40. I think it's probably more scary when you got the guy that you check the blood pressure and it's 70/40 and they start push dose epi and the guy's really got a dissection. You can have a bad outcome. So look at the whole picture. We kind of talked earlier about how you risk stratify patients by the questions you ask. So if you got somebody with chest pain, and then you got unequal blood pressures, and you can kind of think about, okay, that's a concern for a dissection. Or if you got somebody with chest pain, they said, yeah, I've been having stomach pain, and a day ago I had somebody do endoscopy. They put a scope down my throat and looked at me. And I'm gonna think, okay, he just had endoscopy. That's a risk. They could have perked his esophagus, and that's the cause of that. So that's why you ask your questions, not to check the box, they have hypertension, diabetes, but to kind of make you think, what else should I look for? So that's what I kind of think about when you go that route. Back to the tension pneumothorax, remember, they got to have tension before you decompress the chest. You have some people who have COPD that never have good breath sounds and always are breathing hard and hypoxic, and you don't want to put a needle in their chest. Anybody that's sick and you're concerned about your patient, talk to the ER doctor. I'm not saying don't talk to the nursing staff, but I'm saying find that doc and let them know, because they're the ones that would get QI'd, get in trouble by not managing the patient appropriately. And if you approach them in a nice way and show your concerns, they usually would get up and go take a look at the patient.
Yep.
Yeah.
What else you got?
So it's common practice in EMS, at least in the regions where I've worked, for in the initial assessment of a patient complaining of chest pain to poke them in the chest. Hey, does it hurt worse when I poke you? And there seems to be an overreaction or overemphasis on the answer to that question. If they say, "Oh yeah, that hurts worse when you poke on it," then I've noticed a lot of medics just say, "Oh well, it's not ACS then." But
No, it can still be ACS even if
Right.
they have, even if they have reproducible chest wall pain, it can still be ACS.
right,
Yeah.
So I think that's an important point.
Yeah,
The dissection can also give them an ACS.
correct. Yes. Dissection
What'd you
is
say? I didn't
scary.
hear what you said. I'm sorry.
And aortic dissection can cause a stent. Right. Because it's blocking either
The coronaries.
Exactly. Yeah, right. The other thing is, if you have somebody who's having left side of weakness and you got a stroke system patient and you get your EKG and there's a STEMI, like you said, then you think, oh crap, that's not a STEMI or a stroke, it's a dissection. Yeah, right. Yeah.
Yep. Chest pain plus. Yeah, that's right. All right.
All right. Any other questions? If not, we'll wrap it up. Great lecture today, Dr. Eversull, Dr. Ferguson. We really appreciate it.